So, I want you to just close your eyes for a second.
Okay.
Just imagine you are standing in an operating theater. It is, say, 3 in the morning.
Oh, it's always 3 in the morning.
Right, exactly. And the air conditioning is humming, the lights are blindingly bright, and they're reflecting off all those stainless steel instruments. You are a surgeon.
You're exhausted.
Totally exhausted. You just spent 20 minutes scrubbing your hands raw, you're gowned, you're gloved, masked up, and on the table in front of you is a young patient, maybe 20 years old.
And, this patient has the absolute classic story.
Yeah.
They came in writhing in pain, fever, a super high white blood cell count. They couldn't even walk upright because the pain in the lower right side of their belly was just so intense.
Right. You've examined them, you looked at the labs, and you are absolutely convinced, 100%, this is appendicitis.
It's the bread and butter of emergency surgery.
It really is. So you make your incision, you dissect down through the layers of fat and the muscle, you enter the abdomen, you reach in with your forceps to pull up the appendix.
Expecting to see this swollen, angry, red, just bursting sausage of an organ.
Exactly. But you pull it up, and it is pink. It's thin. It's soft. It is perfectly, maddeningly innocent.
Yeah, that moment.
Yeah.
That specific visual gives literally every surgeon a visceral, sinking feeling in the pit of their stomach. It's the nightmare scenario.
Because looking at that normal, healthy appendix means two really terrifying things.
Right. First, you just performed invasive surgery on a young person for absolutely no reason. You've inflicted trauma without a cure.
Which is bad enough. But the second thing...
The second thing is so much worse. The thing that is actually killing your patient, it's still in there. Hiding. And because you were so sure it was the appendix, you might not have any idea what else to even look for.
And that nightmare scenario is the premise of today's deep dive. We are entering the minefield.
Yes, we are.
We're looking at a stack of fascinating lectures and notes from the Surgical Thinking Academy, and it focuses entirely on the right iliac fossa.
The RIF.
Right, the lower right part of your gut.
Yeah.
And they call this the most diagnostically treacherous area in the human body.
It absolutely is. And usually when we talk about this area, the question is really simple, right? What is appendicitis?
Yeah, that's the standard teaching.
But the material we are diving into today flips that entirely on its head. The question we're asking is much harder and honestly way more important for your critical thinking. We're asking, what is not appendicitis?
Because, as we're going to find out, there's a massive list of imposters. We're calling them the great pretenders.
I love that name.
Right. These are conditions that mimic appendicitis so perfectly they fool even the absolute best surgeons. And while this material is technically, it's drawn from board prep for doctors.
MBBS, USMLE candidates, yeah.
Exactly. But the logic here, the detective work, it's something everyone needs to hear. Because if you're interested in decision-making under pressure or fighting cognitive bias, this is for you.
It's the classic hammer and nail problem. When you have a hammer, everything looks like a nail. When you're a general surgeon, every right-sided belly pain looks like an appendix.
And we are here to dismantle that assumption.
Completely.
So let's start with the crime scene itself. The right iliac fossa. Why is this specific patch of real estate such a disaster zone for diagnosis?
It comes down to overcrowding. It really does.
Yeah.
If you think of the abdomen as a sprawling city, the right iliac fossa is the highest density housing district in town.
It's packed.
It is absolutely packed with tenants.
So who lives there? Give us the directory.
Well, obviously the tenant everyone knows, the celebrity, is the appendix.
Mm-hmm.
But living literally on top of it, underneath it, or wrapped around it, you have a huge crowd. You have the terminal ileum.
Which is the very end of the small intestine.
Right, where it dumps into the large bowel.
Yeah.
You have the cecum, which is the start of the colon.
Okay, so lots of plumbing.
But it's not just plumbing. You have the ureter running right through the backyard.
The tube from the kidney to the bladder.
Exactly. You have the psoas muscle, this massive hip flexor running behind it. You have the iliac arteries and veins, which are major highways for blood, a massive network of lymph nodes. And if you are a woman, you have the right ovary and the fallopian tube sitting right there in the living room.
That is a wildly crowded apartment complex.
It is. And here is the fundamental physiological problem with all of that. The brain is actually terrible at localizing pain from the inside of the body.
Visceral pain.
Right, visceral pain. Almost all those structures I just listed, they share the same nerve roots. They basically use the exact same telephone line to call the brain.
So the brain gets a call, but it doesn't know which room the call is coming from?
Exactly. To your brain, A distress signal from the ovator, a signal from the ureter, and a signal from the appendix all show up on caller ID as, vague pain in the lower right belly. There are literally 15 different diagnoses that all live at that one exact address.
And to make matters worse, the source material describes the appendix itself as a chameleon organ, meaning it doesn't even stay put in its own house.
No, it doesn't. And this is one of those frustrating evolutionary quirks of the appendix. It is the most positionally variable organ in the human body.
Right, because it's attached at the base.
Sure, it's anchored there.
Yeah.
But the tip can be anywhere. It's like a tail that can wag in any direction.
So where does it actually hide?
Everywhere. The classic textbook teaching is that it just hangs down freely. But often, it is retrocecal.
Meaning behind the cecum.
Tucked up behind the large intestine, sandwiched between the bowel and the back muscles.
And if it's hiding back there, does it feel different to the patient?
Completely different. If a retrocecal appendix gets inflamed, it doesn't touch the front of the abdominal wall. So when the doctor presses on your tummy in the ER, it might not hurt much at all. Instead, it irritates the muscles of the back. So the patient comes in complaining of back pain or flank pain.
So the doctor immediately thinks kidney stone, or maybe a pulled muscle. They don't think appendix.
Exactly. Or it can be pelvic, meaning it hangs down really low into the deep pelvis. If it's inflamed down there, it irritates the bladder or the rectum.
So the symptoms change again?
Right. The patient comes in with urinary urgency, feeling like they need to pee constantly, or they come in with diarrhea because the rectum is irritated.
And the doctor diagnoses a UTI or a stomach bug.
They send them home with antibiotics or hydration, thinking it's just gastroenteritis, and then the appendix bursts 2 days later.
That's terrifying.
The appendix mimics its neighbors simply because it can physically move into their territory. The appendix can mimic other things just as easily as other things mimic it.
Okay, so because of this overcrowding and this shape-shifting ability, mistakes happen. And this brings us to the segment of the research that honestly just shocked me.
The negative appendicectomy rate.
Yes. The percentage of times surgeons operate for appendicitis and remove a perfectly normal organ. Walk us through these numbers.
Historically, the medical community has accepted a rate of about 15 to 20%.
1 in 5 surgeries is completely unnecessary.
Yes.
That seems incredibly high for modern medicine.
It is high.
Yeah.
But it actually gets worse. In women of reproductive age, say roughly 15 to 45, that error rate can shoot up to 25, 30, and some studies even show 40%.
40%, nearly half the time they are taking out a normal appendix in young women.
Yeah.
Why on earth was that ever considered acceptable practice?
It was a very cold calculation of risk versus benefit.
Yeah.
You have to understand the context from back before advanced imaging, like CT scans, became super common. The old surgical dogma was always, it is better to take out a normal appendix than to miss a bad one and let it perforate.
Because a burst appendix is a known killer.
Exactly. A perforated appendix causes peritonitis, massive sepsis, and death. So surgeons were trained to be highly aggressive. If there was any doubt at all, you cut it out. The thinking was basically, well, the appendix is useless anyway, so no harm done.
But the Surgical Thinking Academy materials we're looking at today, they really push back hard on that idea. They argue that taking out a normal appendix is not just some harmless oops moment.
No, it is absolutely not harmless. We have to dispel that myth right now. First off, you have the baseline surgical risks.
Right. Going under the knife is never zero risk.
Anesthesia itself carries a risk of death. You can get a wound infection, you can get a hernia at the incision site years later. You can develop adhesions, which is scar tissue inside the belly that can twist the bowel and cause a life-threatening obstruction 10 years down the line.
So you're creating lifelong risks for a problem that didn't even exist.
Correct. But the deeper danger, and this is the really critical insight for you listening, is the misdiagnosis. This is what keeps the experts up at night.
Explain that dynamic.
If you go in, you find a normal appendix, you take it out, high-five your assistant, and would go home. You have failed. Because the patient did have pain. There was a pathology causing that pain.
Right. They didn't come to the ER for fun.
Exactly. If that pathology was, say, Crohn's disease or a tumor or a twisted ovary, and you stopped looking because you were just so focused on the appendix, that patient's going to get worse.
That is the detective shift right there. Finding a normal appendix isn't the end of the case. It's a giant clue that the case just got much more complicated.
Precisely. It's the signal that you are actively looking at a mimic.
So let's start the hunt. We are going to become diagnostic detectives today. Let's run through these great pretenders, the conditions that mimic appendicitis so well they fool the pros, The source material breaks these down into neat categories. So let's start with the immediate neighbors in the gut, the gastrointestinal mimics.
Okay, the big boss here, the one that is almost utterly indistinguishable from appendicitis, is something called Meckel's diverticulum.
Meckel's diverticulum. It sounds like a spell from a fantasy novel. What exactly is it?
It is a congenital anomaly,
Hmm.
basically a birth defect. When you were an embryo, there was a connection between your gut and the yolk sac. Usually that totally disappears as you develop. But in some people, a little piece of it remains. It forms this small pouch, a blind tube, sticking right off the side of the small intestine.
And the notes give us this incredible memory hook for it called the rule of twos. I love a good mnemonic.
It's classic medical school trivia, but it actually holds up surprisingly well in practice. Meckel's occurs in 2% of the population. It is usually located 2 feet from the ileocecal valve, which is the junction between the small and large bowel.
Okay, 2%, 2 feet.
It is about 2 inches long. It often contains 2 types of ectopic tissue. It's 2 times more common in males, and it typically presents around age 2.
That is oddly consistent. But wait, you glossed over something wild. Ectopic tissue, meaning tissue in the wrong place.
Right. This little pouch in the small intestine can contain gastric mucosa stomach lining or pancreatic tissue.
Wait. You have stomach lining inside your intestine 2 feet away from your actual stomach.
Yes. And think about what stomach lining does. Its entire job is to produce acid to digest food. So you have this ragged little patch of tissue pumping out hydrochloric acid directly inside the small intestine.
But the small intestine isn't built for that.
Not at all. It doesn't have the thick, protective mucus coating that the stomach has.
It literally burns.
It burns, it ulcerates, it bleeds, and it gets highly inflamed. And when it gets inflamed, Meckel's diverticulitis, it sits in the exact same spot as the appendix. It hurts in the exact same way. You physically cannot tell the difference from the outside.
So you're the surgeon, you've opened the patient up, the appendix looks white and happy. What do you have to do?
You must follow the protocol. You have to check the small bowel. Specifically, the rule is you have to run the bowel.
What does that mean?
You physically pull out the small intestine, hand over hand, for at least 60 centimeters, about 2 feet, to explicitly look for this Meckel's pouch.
You literally measure out 2 feet of intestine with your hands.
You have to. If you don't look for it, you won't see it. And if you miss it and you close the patient up, you are leaving them with a perforating ulcer inside them. That can easily be fatal.
Wow. Okay, that's a very tangible procedural check. Now, there is another GI mimic that sounds even scarier because it comes with a strict do not touch warning. This is Crohn's disease.
Yes, specifically terminal ileitis. Crohn's is an inflammatory bowel disease. It's an autoimmune condition where the body literally attacks its own gut. And it absolutely loves to attack the very end of the small intestine right next door to the appendix.
What does that actually look like when you're looking at it in the OR?
It's incredibly distinct. The bowel looks terribly angry. It's thick, swollen, and bright red. The description in the textbooks is often like a rubber hose because it gets so stiff. And you see this fat from the mesentery wrapping all around the bowel, physically trying to wall off the inflammation. We call that creeping fat.
Creeping fat. That is such a visceral image. So you see this angry rubber hose bowel with creeping fat. Why is the appendix so dangerous in this specific situation?
Because sometimes that severe inflammation spreads right onto the base of the appendix. And the golden rule of surgery here, tattoo this on your brain. If the base of the appendix is involved in Crohn's disease, you must not remove it.
Even if you are already inside, you have the scalpel right in your hand.
You have to back away. Because Crohn's tissue is intensely diseased. It is falling apart. It does not heal well. If you cut through that inflamed tissue to take the appendix off, and then you try to stitch it closed, the stitches will not hold.
They just break.
They will pull right through the tissue like cutting cheese with a wire.
Oh my God. And then what happens?
And then you have an open hole in the bowel. You've caused a fistula, a permanent leak of bowel contents, feces, into the abdomen or even out through the skin. It's a devastating complication. It leads to months of sheer misery, sepsis, and often requires a stoma bag.
So the discipline there is to see the inflammation, recognize it as Crohn's, and say to yourself, I am not touching this.
Exactly. You leave it in, you close the patient up, and you treat them medically. Steroids, biologics. You treat the immune system, not the organ. And that takes a huge amount of confidence when you've been trained your whole career to fix things by cutting them out.
So true. All right, let's move up the age bracket. We talked about Meckel's in kids and young adults. What if a 60-year-old comes into the ER with this pain?
The fear shifts entirely. In older patients, the great mimic is carcinoma, cancer of the large bowel.
And the source material mentions an age rule here.
The rule is extremely clear. Any patient over 40 presenting with new right iliac fossa pain must get a CT scan. Period. You do not rush them to surgery.
Why is a CT scan so completely mandatory for them?
Because a tumor in the cecum can physically block the opening of the appendix, actually causing appendicitis. Or the tumor itself can just hurt and mimic the symptoms. If you go in there thinking it's a simple, quick appendix removal, and you find a large, ugly cancer mass adhered to the sidewall of the abdomen, you are in deep, deep trouble.
You're just not prepared for that level of surgery.
You aren't. You might not be prepped for a major cancer resection. You probably don't have the right consent from the awake patient to remove half of their colon. You might even make it worse by cutting blindly into the tumor and spreading cancer cells. You need the roadmap, the CT scan, before you start the car.
That makes total sense. It really seems like as you get older, the stakes change dramatically. But let's pivot to the demographic where the error rate is the absolute highest, where the stakes are high in a completely different way. Women of reproductive age. We said up to 40% of these surgeries are negative. Why is the female reproductive system such an effective mimic?
It's sheer proximity. The right ovary and fallopian tube are literally sharing a bunk bed with the appendix. And they are highly active organs. They cycle, they release eggs, they twist, they bleed. They are very noisy neighbors.
And there's one condition here that the expert in the source calls the time is muscle equivalent for gynae. Ovarian torsion. What is that?
This is a true surgical emergency. The ovary isn't bolted down tightly. It hangs on a ligament, sort of like a light bulb hanging from a cord. Sometimes, especially if there's a cyst making it top-heavy, it flips over. It twists the blood vessels, the vascular pedicle, exactly like wringing out a wet towel.
And that completely cuts off the blood supply.
It strangulates the organ. The ovary immediately starts to die. It becomes necrotic. You have a very, very short window, maybe 6 hours, to get in there and manually untwist it. If you miss that window, the ovary is dead. You have to remove it.
Which is devastating.
For a young woman hoping to have children, losing an ovary is a major life-altering event.
Time is ovary, as they say.
Exactly. Now, here is the diagnostic trap. You suspect torsion. You send the patient for an ultrasound with Doppler. The report comes back from radiology. Ovaries visualized, blood flow present. You breathe a huge sigh of relief and say, okay, great, it's not torsion.
Wait, is that wrong?
It is an incredibly dangerous assumption. The source emphasizes this heavily. Blood flow on a Doppler scan does not rule out torsion.
How is that even possible? I mean, if the machine sees blood flow, there's flow, right?
You have to think about the physics of the plumbing. You have arteries bringing blood into the ovary and veins taking blood out. Arteries have thick, muscular walls. They are high-pressure pipes. Veins are floppy, thin tubes. They are low pressure. When the ovary twists, the very first thing that gets compressed is the floppy vein.
So the exit gets blocked first.
The exit is blocked, but the entrance, the high-pressure artery, is still pumping open. So blood keeps pumping into the ovary, but it can't get out. The ovary swells up, becoming massive, purple, and angry.
So the Doppler ultrasound just sees the arterial blood going in and reports flow present?
Correct. But the ovary is actively dying from congestion. Or the ovary might be twisting and untwisting, intermittently torsion to torsion. The scan just happened to catch it in a good moment. The overarching lesson is, clinical suspicion trumps the scan. If a woman is in severe, sudden, colicky pain, you have to consider torsion even if the machine tells you otherwise.
That is terrifying, honestly. Relying on the machine could cost someone their fertility. But there's another gynecological mimic that is literally a matter of life and death: ectopic pregnancy.
This is the one you absolutely, categorically cannot miss. If you miss an ectopic, the patient can bleed to death in the waiting room.
This is when a fertilized egg implants outside the uterus, usually right in the fallopian tube.
Right. And the fallopian tube is a tiny, fragile little structure. It's not designed to stretch and grow like the uterus is. As the pregnancy grows, it stretches that tube until it simply bursts. The bleeding is internal, and it is torrential. A patient can lose liters of blood into their abdomen very, very quickly.
The source material lays down a very strict rule about this. They call it the absolute rule.
The absolute rule is, every single woman of reproductive age, from the day of her first period to the day of menopause, who comes in with abdominal pain gets a urine pregnancy test. First, before the CT scan, before the blood work, before you even lay a hand on her belly.
It doesn't matter if she swears she's on the pill.
Doesn't matter. Pills fail all the time.
Doesn't matter if she says she hasn't had sex in a year.
Doesn't matter. Patients lie, patients forget, or patients are just mistaken.
Mm.
The rule is absolute because the cost of missing it is death.
There's a story in the notes about an anesthetist that really drove this home for me.
Yes, this is a chilling story. A patient was actively being prepped for surgery for suspected appendicitis. The surgeon was scrubbed at the sink. The patient was already on the operating table. But the anesthetist, just doing their final safety check, noticed something off on the chart. The date of the last menstrual period was weeks ago.
Hmm.
Just to be completely safe, they did a quick bedside pregnancy test right there in the pre-op area. Positive. It wasn't appendicitis at all. It was a leaking ectopic pregnancy.
Hmm.
If they'd gone in with a laparoscopic trochar, that's the sharp port they use for the camera in the wrong spot, or if they had mishandled that swollen tube thinking it was an appendix, they could have triggered massive uncontrollable hemorrhage. That one simple urine stick saved her life.
It's such a cheap, fast test. There's really no excuse not to do it every single time.
None. It is straight up medical negligence not to do it.
Okay, let's talk about PID, pelvic inflammatory disease. There's a clinical sign mentioned here called the chandelier sign. I have to ask, what exactly is that?
It's very vivid imagery from the old days of physical diagnosis. PID involves severe inflammation of the cervix and uterus, usually from a sexually transmitted infection. During a pelvic exam, if the doctor touches or moves the cervix, the pain is so sudden and excruciating that the patient symbolically reaches for the chandelier on the ceiling to pull themselves away from the doctor.
Got it. Extreme tenderness on motion.
Yes, if you have that cervical excitation, it's almost certainly gynae, not the appendix. The appendix doesn't care if you move the cervix.
One more gynae term, Mittelschmerz. It's just a really fun word to say.
It is German for middle pain. It happens exactly in the middle of the menstrual cycle, usually around day 14. When the ovary releases an egg during ovulation, a little bit of fluid and blood irritate the peritoneum, which is the lining of the abdomen. It hurts, often sharply on the right side, but it's completely harmless. It goes away on its own in 24 hours.
So literally just checking the calendar can save you from unnecessary surgery.
When was your last period is the most important question in the history taking. If it was 14 days ago, you pause and wait.
Okay, so we've covered the neighbors that live in the GI tract and the reproductive system. Now let's look at the plumbing and the framework. The urological and musculoskeletal mimics. Kidney stones are the big one here.
Ureteric colic, a stone passing down the incredibly narrow tube from the kidney to the bladder. It hurts like hell. Many women actually say it's worse than childbirth.
But the pain presents differently, doesn't it? The source discusses this bedside test where you don't even have to touch the patient to tell the difference between a stone and an appendix.
This is the real art of medicine. You stand at the foot of the bed and you just watch. You observe the patient's behavior before you say a word.
What are we looking for?
We're looking at movement. If the patient has appendicitis, they have peritonitis. That means the lining of the abdominal wall itself is inflamed. Every single time they move, that inflamed lining rubs against the muscle, and it is sheer agony. So an appendicitis patient lies frozen. They are statues in the bed. They take really shallow breaths. They will tell you that every bump in the road during the ambulance ride felt like a knife.
Okay, so a still patient equals peritonitis, which likely equals appendix.
Now look at the kidney stone patient. Their pain is visceral. It's coming from a hollow tube, desperately trying to squeeze a jagged rock through. It comes in intense waves colic. They cannot get comfortable no matter what they do. They are pacing the room. They're rolling around on the bed. They're constantly writhing.
So a restless patient equals a stone.
Generally, yes. It's a very strong visual clue before you even do an exam.
What about the muscles themselves? You mentioned the psoas muscle runs right through this exact area.
It does. And you can get a psoas abscess. This is a literal collection of pus deep inside the muscle. Historically, this was very often tuberculosis TB of the spine draining down into the muscle. We still see it in developing countries or in highly immunocompromised people.
And there's a specific physical test for this, the psoas sign.
Right. You have the patient lie on their left side, the healthy side. You grab their right leg and you pull it back, extending the hip. This deeply stretches the psoas muscle. If there is an abscess inside that muscle, stretching it causes immense sharp pain.
Interesting. And there's also something here called an iliopsoas hematoma, which is basically just a really big internal bruise.
A massive internal bleed. This is specifically a huge trap in elderly patients who are on blood thinners like warfarin.
Yeah.
They come in with right-sided pain. If you assume it's appendicitis and take them to surgery, you are cutting into a patient whose blood literally does not clot. It's a total disaster.
So if they are on blood thinners, you stop.
You check the clotting levels, the INR, immediately. If it's high, it's likely a bleed in the muscle, not an infection. You treat that by fixing the blood, giving vitamin K or plasma, not with a knife.
All right, we've talked a lot about things actually in the abdomen, but what about when the body plays a trick on the belly? The systemic mimics. These conditions that have nothing to do with the abdomen, yet the pain mysteriously shows up there.
This is where the detective work gets really sophisticated. The first big one is DKA diabetic ketoacidosis.
This is a life-threatening complication of diabetes. Why on earth does it cause belly pain?
It's a systemic metabolic storm.
Hmm.
The blood becomes highly acidic, you get severe dehydration and massive electrolyte shifts. This causes the smooth muscle in the gut to cramp up, and you get gastric stasis, meaning the stomach just stops working. Young people with undiagnosed type 1 diabetes very often present with vomiting and severe abdominal pain.
It mimics an acute surgical abdomen perfectly.
It does. And imagine the tragedy here. You take a patient in a severe metabolic crisis, you put them under anesthesia, which is a huge physiological stress, and you cut them open. You make the diabetes exponentially worse. You push them right to the edge.
And the solution to avoid that is so simple.
Check the blood sugar. Always. A simple finger prick saves you from the scalpel.
And then there's pneumonia, a lung infection. How does a lung infection feel like a bellyache? That seems completely counterintuitive.
It's called referred pain. We are back to the wiring problem we talked about earlier. The nerves that supply the lining of the lungs, the pleura, especially the lower lobes, they overlap directly with the nerves of the upper abdomen, specifically thoracic nerves T9, T10, and T11.
So the brain gets confused again.
Exactly. If you have a raging pneumonia in the right lower lobe of the lung sitting right on top of the diaphragm, the brain registers it as pain in the right iliac fossa.
The source mentions a golden rule for kids regarding this.
Yes. Every child with abdominal pain needs a chest x-ray. It is non-negotiable.
Every single child, even if they aren't coughing or wheezing?
Every child.
Yeah.
Kids very often don't cough with pneumonia. They just present with a high fever and belly pain. The expert in the source material tells a great story of a child who was fully prepped for an appendectomy. But the routine x-ray showed a big white patch of consolidation in the right lung. They canceled the surgery right then and there, gave the kid Camille antibiotics for the pneumonia, and the appendicitis magically vanished.
That is a phenomenal catch. One more systemic mimic for kids, HSP.
Henoch-Schönlein purpura. It's a vasculitis, which means inflammation of the small blood vessels. It aggressively affects the gut, causing severe pain and bleeding, but it also heavily affects the skin.
So what are we looking for in the skin?
A rash. Specifically palpable purpura. These are little raised purple spots that don't fade away when you press on them. They usually appear prominently on the buttocks and the backs of the legs.
So the overarching lesson is lift the gown.
Always, always lift the gown. Inspect the whole patient. If you see those spots, it's HSP. Put the scalpel down immediately. It's a medical condition, not a surgical one. It's treated with steroids and supportive care, not surgery.
Okay, we have this huge, intimidating list of potential imposters. We need tools to sort them out. The source material discusses the diagnostic toolbox. Let's talk about the Alvarado score.
This is a widely used clinical scoring system. It's a checklist to rate the probability of appendicitis. It really helps junior doctors make objective decisions. The mnemonic to remember it is Mantrels.
Break that down for us. Mantrels.
M is for migration of pain. Classic appendicitis starts vaguely in the middle, near the belly button, and then migrates down to the right side. That's a huge key sign. A is for anorexia, meaning loss of appetite. If the patient is hungry and asking for a burger, it's probably not appendicitis.
Makes sense.
N for nausea. T for tenderness in the right lower quadrant. R for rebound tenderness.
This rebound.
It means it hurts more when you suddenly let go of the skin than when you press down. E is for elevated temperature, a fever. L is for leukocytosis, which is high white blood cells. And S is for a shift to the left, which is a very specific lab marker of fresh, acute infection in the blood.
So you basically just add up the points from that checklist.
Right, a score below 4. Unlikely to be appendicitis, you need to look for something else, a score of 7 or 8, highly likely. It forces you to be systematic and objective rather than just relying on a hunch.
What about ultrasound? We mentioned it was crucial for gynec stuff. Is it good for the appendix itself?
Ultrasound is fantastic for ovaries and uteruses. It is generally terrible for the adult appendix.
Why is that? I thought ultrasound sees everything soft.
Because the appendix is a hollow tube. If it's filled with gas, sound waves literally bounce right off it. If it's hiding behind the bowel, the gas in the bowel blocks the view completely. If the patient has a thicker abdominal wall, the waves just don't penetrate well enough to see that deep.
So if the radiology report says appendix not visualized, what does that actually mean?
It means absolutely nothing. It does not mean the appendix is normal. It just means the radiologist couldn't find the invisible man. You cannot be reassured by a negative ultrasound in an adult.
So what is the gold standard? What imaging actually sees everything?
The CT scan, computed tomography. It gives you a perfect slice-by-slice map of the entire abdomen. It definitely sees the inflamed appendix. But much more importantly for our discussion today, it sees the mimics. It sees the kidney stone. It sees the ovarian cyst. It sees the diverticulitis. It sees the cancer.
But there's a debate here, right? Should everyone just get a CT?
That's the main controversy. CT involves radiation. It's equivalent to hundreds of standard chest x-rays. We worry about causing cancer down the line, especially in very young people. So in a young male with a totally classic Mantrell story, maybe you skip the CT and just operate.
But for everyone else?
For women, for the elderly, for anyone with a confusing or vague story, the consensus is definitely shifting toward scan them. The risk of the radiation is generally considered lower than the risk of a negative surgery or missing a huge cancer.
Except obviously for pregnant patients.
Right. No radiation for the baby.
Yeah.
So for pregnant patients, if the ultrasound fails to give an answer, we use MRI, magnetic resonance imaging. Zero radiation. Excellent soft tissue detail. It's the safe path.
Okay, let's go back to the operating room. The moment of truth. We are the surgeon. We've done the workup. We've decided to operate. We open the patient up. And despite all our best efforts, the appendix is white and innocent.
It happens. Even with CT scans, it still happens. Now you have to immediately switch into protocol mode. You cannot just close up and hope for the best. You have to actively find the problem.
Walk us through this intraoperative checklist. Step 1.
Step 1. Check the appendix again. There is something called microscopic appendicitis or endoluminal appendicitis.
Yeah.
It might look perfectly normal on the outside, but be severely ulcerated on the inside. So standard practice, unless there is that Crohn's base we talked about, is to remove the appendix anyway and send it to the histology lab.
So you take it out just to rule out the microscopic stuff. Step 2.
Step 2 is the Meckel's hunt. You run that small bowel. You physically handle those 2 feet of intestine. You look for the pouch. Step 3. Check the cecum and colon. You are palpating, feeling carefully with your fingers for hard masses, hidden tumors, or diverticulitis. You are physically checking the neighbors. Step 4. Check the mesenteric nodes. These are the lymph nodes situated in the root of the bowel. In kids, these often get huge and swollen just from viral infections, like a common throat cold. It's called mesenteric adenitis. It mimics appendicitis perfectly. If you see big, succulent, pink lymph nodes, that's almost certainly your answer. You don't need to cut them out. They will shrink completely on their own.
Step
4. Female patients, you have to look down into the pelvis. Look at the ovaries. Is there a cyst? Is there torsion? Look at the tubes. Is there an ectopic mass? Look at the uterus. Is there actual pus coming out of the tubes indicating PID? You have to visually confirm the reproductive organs.
Step 6.
Palpate the kidneys and ureters from the inside. You can literally feel a hard stone sometimes. You can feel if the kidney is swollen from a blockage.
And finally, step 7. Check the fluid.
Yes. Is there free fluid in the belly? Dip a strip in it. Smell it. If it's clear, it might just be viral. If it's pus, there's obviously an infection somewhere. If it's bile, something is perforated high up in the gastrointestinal tract, like a burst ulcer in the stomach. If it's blood, something is actively ruptured. The color of the fluid tells a very clear story.
It's really a highly systematic investigation. You don't just shrug and leave.
Never. You check every single room in the house before you walk out the door.
Before we wrap up, let's briefly touch on special populations. We mentioned the elderly and women. What about children?
Kids are really hard because they are poor historians. My tummy hurts could mean literally anything from I eat way too much candy to my appendix has completely burst. They get that mesenteric adenitis we just mentioned, and their anatomy is just smaller, thinner. Perforation happens much faster in kids. The omentum, which is sort of the policeman of the abdomen, this fatty apron that physically moves to wall off infection, it is underdeveloped in little kids, so they get sicker much faster.
And what about the immunocompromised, people on chemo or high-dose steroids or with advanced HIV?
They are the silent patients.
Yeah.
Their immune systems are so deeply suppressed that they just don't mount a fever. They don't make enough white blood cells to show leukocytosis on the labs. They don't complain as loudly because the inflammation itself isn't as robust. But they could be the sickest patients in the hospital.
Is there a specific mimic for them?
Yes, typhlitis. It's a neutropenic enterocolitis.
Mm.
Basically, the gut wall breaks down and gets infected because the white cell count is so dangerously low. It happens frequently in chemo patients. It mimics appendicitis perfectly, but surgery is usually the exact wrong choice. Operating on that friable tissue often kills them. You need to treat the immune system and give heavy IV antibiotics.
And lastly, pregnancy. We talked about ectopic pregnancies, but what about actual appendicitis occurring during pregnancy?
The enormous challenge there is anatomical migration. As the baby grows, the expanding uterus pushes everything up and out of the way. The appendix literally migrates from the lower right quadrant to the upper right quadrant, or sometimes even all the way into the back flank.
So a pregnant woman with appendicitis won't even point to the usual spot.
No, she might point up to her ribs
Uh,
or her back. If you don't know that specific anatomical shift happens, you will absolutely miss it. And a burst appendix in pregnancy can trigger preterm labor or fetal loss. The stakes are just incredibly high.
it's amazing how the body adapts and how that adaptation completely confuses the standard diagnosis.
It really is. The body is endlessly complex, and it definitely doesn't read the medical textbooks.
So let's bring this all home. We started with the nightmare scenario of staring at a normal appendix. But through this deep dive, we've learned that the right iliac fossa is a place that demands intense humility.
Absolutely. Humility and a rigorous, systematic approach. Appendicitis shouldn't ever be a reflex diagnosis. It should be an active question. Is this appendicitis?
And if the answer is no, that's not a dead end.
No. As the expert in our source material powerfully stated, finding a normal appendix isn't a failure. It is a diagnostic opportunity. It's your chance and your absolute obligation to find the thing that is actually killing the patient, whether it's a hidden Meckel's pouch, a twisted dying ovary, or a silent pneumonia.
That is a really powerful reframing. It's not about being right the very first time. It's about getting it right eventually, for the patient's sake.
That's the true essence of surgical thinking. It's not just cutting, it's thinking.
And, just to add one final provocative thought for you listening. We've talked all about the dangers of the surgery itself and missing the real mimic, but there's also emerging research suggesting the appendix isn't even the useless evolutionary vestige we've always been taught it is.
Oh, the microbiome research.
Right. It might actually serve as a safe house for good gut bacteria to repopulate your intestines after a severe illness. So taking out a normal appendix isn't just a missed diagnostic opportunity. You might literally be robbing your immune system of its backup generator.
Which just makes the argument for being absolutely certain before you cut even stronger.
Exactly. Well, I will certainly never look at a tummy ache the same way again. There's a whole world going on in that crowded neighborhood.
Indeed there is.
Thanks for listening to this deep dive. Stay curious, stay critical, and we'll catch you on the next one.